Hi everyone, I would like to welcome you to the Nextgen Healthcare webinar, 21st Century Cures Act, 5 years later, what the interoperability rules mean for you. My name is Nicole Scheid and I will be your host for this session. You may submit questions throughout the presentation in the Q&A panel in the WebEx window, and we'll address all questions at the end. Let me introduce you to our speakers. We have Dr. John Ellis, Vice President of Solutions here at Nextgen Healthcare. We have Mohammed Chubli, Vice President of Solutions, also here at Nextgen. Chris Emper, Government Affairs Advisor at Nextgen Healthcare. And Andy Rydell, Senior Director of Solutions at Nextgen Healthcare. So with that, I will pass it over to Chris.
Excellent. Thank you, Nicole, and thank you everyone for joining us today. As Nicole mentioned, I'm Chris Emper, Government Affairs Advisor for Nextgen Healthcare. And my primary responsibility is sitting inside Washington, D.C. and monitoring legislation and regulations that impact Nextgen Healthcare and its clients. So certainly the 21st Century Cures Act has been something that I've spent a lot of time on these last 5+ years, monitoring the development around different rules, rulemakings, initiatives coming out of the Cures Act and the interoperability provisions, especially with an eye towards the impact to you. And when you think of the title of this webinar, 21st Century Cures Act, 5 years later, what the interoperability rules mean for you. In the 60 minutes we have you here today, we're going to talk about the key provisions of the Cures Act, the key interoperability provisions, and I'll walk through and spend about 10 to 15 minutes giving an overview of what those provisions are. And then specifically, we're going to narrow in with a discussion around the health IT certification provisions, the information blocking provisions, and TEFCA. And then at the end, we're going to spend 15 or so minutes, maybe 20 if I talk fast. And we're going to open it up for some Q&A. And please type in your questions into the chat, and we'll try to address as many of them as we can. And, you know, really the goal and the point of this webinar is to take a step back now that we're, over 5 years into the Cures Act being law, and assess what the impact has been not only to the health IT industry, but more importantly to all of you as healthcare providers, because ultimately that's what the goal of these provisions were. So again, our panel, and I'll dive in with an overview of what these provisions are. So for those unfamiliar with what we're talking about here, those who might have clicked and tried to register for something else and don't know what the 21st Century Cures Act and ended up in this webinar, it was a law that was passed in December of 2016. And it's a little bit misleading because primarily what healthcare providers and certainly the health IT industry has been, most focused on related to the Cures Act has been the health IT interoperability and data interoperability rules. But the law itself was a big deal, and it was a big deal primarily around cancer and genomic research and reforms to the FDA regulatory review process, as well as providing funding to the National Institutes of Health and other federal agencies to try to push for cancer and genomic research. So you see here a picture of the signing ceremony. This was actually the last major piece of legislation signed into law by President Obama in December of 2016. The law itself was passed, and you see the vote counts in the House and the Senate, 392 to 26 in the House, 94 to 5 in the Senate, overwhelmingly bipartisan piece of legislation. It was the product of several years of work on a bipartisan basis between the key healthcare committees in the House and the Senate, negotiating over the different details and coming to an agreement on this. And it was something that became a lame duck priority that after the election in November of 2016, they were able to move forward and pass and sign into law again in December of 2016. But as I mentioned, that the focus and a lot of the news coverage when the law was passed and signed was around cancer and genomic research. It had 86 of the almost 1,000 pages in the bill devoted to health IT issues, and specifically what they look to attach here is a package of policies that the committees in the House and Senate had developed over the past few years around trying to improve what they perceived as some of the failings of the Meaningful Use EHR incentive program. So leading up to the passing of this bill, you heard on the Hill and through members of Congress from the physician community and the healthcare community more broadly that the Meaningful Use EHR incentive program was successful in incentivizing the adoption of EHRs, but none of those EHRs were talking to each other. They weren't sharing information. They weren't, participating up to the standards that Congress had hoped when they passed the High-Tech Act in 2009. So in this bill, they provided several different provisions, and ultimately we're going to require HHS and the HHS Office of the National Coordinator for Health IT, ONC, to issue several rulemakings over the next few years to implement those provisions. So that's what the Cures Act was, December of 2016. Obviously, we're midway through 2022, so it's 5.5+ years. We're 5 years later. So I think given the status and the importance of some of these provisions in this rule, in this law, that's kind of what we're here to discuss today. So I mentioned HHS and ONC were tasked with writing the rules under the law. This was a lengthy and complex process that took a few years. There were proposed rulemakings in 2018, 2019. Ultimately, we saw in the public comment period that was a bit extended. Ultimately, as you see the press release here in March of 2020, the final Cures Act interoperability rules were released. There was actually one rule from CMS and one from ONC. The ONC rule is most pertinent to the 21st Century Cures Act. And in the rule, which they're calling the ONC's Cures Act final rule, you see the branding from ONC from their website at the bottom here. There are two main provisions of health IT policies under the Cures Act that are enforced. The first one is dealing with changes to the EHR certification program, or the Health IT certification program, as it's been rebranded. I still call it the EHR certification program, as most of you probably know it as. And then secondly, the implementation of the information blocking provisions under the Cures Act. So in the proposed rule and the final rule ultimately embedded into law many of these provisions. In terms of the EHR certification program and the changes, the Cures Act had a whole list of things, and it was basically a goodie list of things that members of Congress heard from constituents and healthcare providers in the industry that EHR vendors should do, and that this is what you need to do to improve the program. Make the EHR companies go put these new product functions into their products and then certify for them and make that the standard for federal programs, and that'll ultimately improve it. So if you remember the Meaningful Use program I participated, there were 3 stages. Stage 1, Stage 2, and Stage 3. And with that, EHR vendors were forced to comply with federal standards for each stage. Meaningful Use is, of course, kind of over and has been morphed into the MIPS program in the Promoting Interoperability category, but federal programs that still require that certified EHR are being forced to update to the 2015 edition Cures update. And the 2015 edition would have been Meaningful Use Stage 3 because the rules were issued in 2015. So that's where 2015 comes with, if you're a little bit confused. But there's a whole new edition here of certification. So EHR companies that want to maintain their federal certification and support providers that participate in federal programs such as MIPS or ACOs or others that require the certified health IT will be required and are required under this rule to update and create and test with the government-sponsored testing bodies to make sure that they meet the new requirements under the new Cures Act edition. One of the big requirements under this is the FHIR-based APIs. So again, thinking around interoperability and data exchange, that was something that was very important under the law. Part 2, in terms of certification program changes, there's also a whole list of conditions of certification and maintenance of certification requirements. I've listed the categories on the right there, but basically these are required business practices and actions. Some of them involve what a vendor, an EHR vendor, can put into a contract with a client. Some of them require how they have to, support their APIs and work with clients and third parties. Others around continued maintenance and things they have to do every year to maintain certification. So really you're looking at, under the Cures Act, a one-time hit to update all the EHR software to maintain their certification in the program to be Cures certified. And then number 2, an ongoing every year in the future compliance obligation that's quite lengthy in these 7 different categories to essentially maintain certification, for the extended future. So that was really what the Cures Act did. The ONC final rule spelled out these details in quite a lot of detail over many pages. And they finalized, not ONC, but CMS, again, the use of certified health IT to the Cures Act edition is required through federal programs such as MIPS and ACOs. And that transition to that new edition is set for December 31st, 2022. The CMS 2023 proposed hospital inpatient payment rule, which was released in April and is relevant just in that it was the last major CMS payment rule. On page 1299 of that rule, you see here I've highlighted for you, it reinforced what they had already confirmed last year through the physician fee schedule, that the deadline to, as a provider, be live or updated on a 2015 edition Cures Update certified product is set for December 31st, 2022. But remember that's, and as I've highlighted here, and you can see in the fine print, that's for your participation in a federal program. So if you only need 90 days of certified health IT in 2023, you can wait until the later 90-day period. You don't have to be, using this Cure Certified update as of January 1 of 2023. But overall, as we think of 5 years later, what's the impact of the Cures Act around certified health IT? The law was passed in December of 2016. We're looking at a basically January 1, 2023, cutoff to be live on the new Cures Edition certified EHR. With that, I'll mention, and we'll get into this a little bit when we open up for questions in the panel, but Nextgen Enterprise EHR did achieve ONC Health IT Cures Update certification back in March. So as other vendors have been busy on this over the last few years, as has Nextgen, as you can see here in the press release, the first EHR vendor to achieve the complete EHR certification under the program. So that's the overall update, and just a quick run through to give you a sense of what's in the EHR certification portions of the Cures Act. In terms of information blocking, probably a little bit more complex, and there are some more direct compliance obligations for healthcare providers here. So certainly listen up if this isn't something that you're familiar with or something that you have some questions around. But information blocking as defined by the Cures Act is a practice that, except as required by law or covered by an exception, is likely to interfere with access, exchange, or use of electronic health information. And as you see, numbers 2 and 3, depending on what actor you are in the program, and the regulated actors that this applies to are health IT developers of certified health IT, so certified EHRs, health information exchanges and networks, and also healthcare providers. And you see the list of healthcare providers there, which is extremely expansive. I mean, the information blocking does not just apply to providers in Medicare. It applies broadly, across all payers, and is one of those obligations that's not restricted to, MIPS or the Quality Payment Program. It's sort of across all programs as applicable if you're a provider. But there's some knowledge requirements in the second and third bullets. And overall, you can see, and this is a slide from ONC on the left, information blocking has these different elements, but it's basically, a complex way of saying that if you don't meet an exception, if it's not required by law, it's not covered by an exception, and it's likely to interfere with access, exchange, or use of electronic health information, you have to share information with, a patient or a provider that's approved under HIPAA for data exchange. So in the Cures Act final rule, they went through and listed in great detail the exceptions and different scenarios that might apply under this rules. A lot of confusion in the industry. The rules went into effect April 5th of 2021 last year, so they are now in effect, but they're not being enforced essentially because the penalties and the enforcement mechanisms, and this on the left here side of the screen here, again, is a slide from from ONC, details that they have not released the final rule to enforce the civil monetary penalties and the assessment of those penalties from the Office of the Inspector General at HHS, and we're waiting for that final rule to assess and implement. Ultimately, ONC has said HHS will not be enforcing the rules until that's final. But also for healthcare providers, the law, the Cures Act says there have to be appropriate disincentives that you see there listed by ONC, and HHS has to establish those through future rulemaking, and that has yet to happen. So we're in this period where the rules are in effect, but they're essentially not being enforced, and we're waiting on future guidance and rulemaking. Meanwhile, on the right side of the slide here, you see that many of the physician advocacy organizations are still pushing back and saying, these rules are overly complex, they don't make sense. some of the issues around immediate release of patient lab results to the portal, which is something we'll talk about a little bit later in the webinar, has created a lot of confusion and potentially could cause, patient harm and distress. So not only are we waiting on future guidance, but there's also an advocacy effort to potentially change parts of the rule. So, again, 5 years, 5.5 years later, the rules are in effect. They're not being enforced. They're incomplete. So we're still kind of moving along and haven't quite reached the promise of information blocking as outlined in the Cures Act. And HHS and ONC leaders, their leadership, HHS Secretary Becerra and ONC Head Mickey Tripathi, they have acknowledged this. As recently as April at the ONC annual meeting, they both said these rules are long overdue. This should be a big year in health IT. We're waiting to get these rules out. We're aware that, we're not where we want to be. But that's kind of where we are for information blocking. But, still, given this period we're in right now where the rules are technically in effect, a lot of questions from physician groups, from providers around what your responsibilities are under the Cures Act now, in the future when those penalties come, to stay ahead of that. So, certainly an issue worth staying on top of and making sure you understand it to the extent those questions and guidance have been provided by ONC and HHS at this time. So the last thing I wanted to talk about is TEFCA, the Trusted Exchange Framework and Common Agreement. So I mentioned that the Cures Act final rule in March, of 2020 covered the EHR certification and information blocking. It did not cover TEFCA because TEFCA is a separate provision of the Cures Act, and you see at the top there, Section 4003B, the National Coordinator shall convene appropriate public and private stakeholders to develop and support a trusted exchange framework for trust policies and practices and for common agreement for exchange between health information networks. So basically, this was the provision that satisfied or attempted to satisfy the request of those in the healthcare industry that came into members of Congress and said, we have all these HIEs at the state level, regional level. We have national networks like Commonwealth and Care Quality, and they don't talk to each other and they don't connect. How do we make that happen? Can you enforce a federal regulation to make that happen? And essentially, Congress said, we're not going to mandate that, but we will task ONC with creating this trusted exchange framework and a common agreement that will enable it. So it was intended to be a voluntary program that would allow those networks to enable exchange. So this, like the other Cures Act requirements, went through some proposed drafts. The final draft came out January of this year, 2022, and you see the press release on the left there. The acronym to get used to, beyond TEFCA, for those information networks that are certified under the program, is QHIN, Qualified Health Information Network. And basically, under what they put out in January, the government contractor or recognized coordinating entity, RCE is a term you'll see another acronym in TEFCA used, which is the Sequoia Project. They have been tasked with certifying and basically testing information exchanges and networks that want to be part of TEFCA to give them their stamp of approval and run through the program. So again, the final press release and paper that outlined an agreement of what you would have to do to participate in TEFCA as a QHIN was released in January. The timeline to operationalize TEFCA, and this comes from the RCE, the Sequoia Project that's charged with running and implementing TEFCA, rolls out over the next few years. So again, 2016 law, December of 2016 signed. We're still looking into the future to see ultimately the impact, but 2022, this is the year. The TEFCA has been finalized. We're implementing it. It's going to become actionable this year. Whether or not how fast that happens remains to be seen, but hopefully we can provide some more details around that. But this is what we're looking at from TEFCA, and ultimately, this is their slide that shows how data exchange will work, with the QHINs, the RCE, and ultimately the participants and sub-participants. I think you as providers might have some questions on exactly how and where you fall under this map, but that's what we're here to do, is to help answer those questions and dive a little bit deeper on some of these details. So with that, that's my run through, and hopefully gives you a bit of a high level understanding of the Cures Act provisions, where they're at 5.5 years later in terms of implementation. We now want to turn to a discussion. We have a great panel here today, as Nicole introduced at the top. who are really, have led the charge from Nextgen Healthcare's perspective in these various different initiatives in ensuring that, the company's been successful in supporting clients and the market with the Cures Act from a compliance standpoint, but also from a business practices standpoint. So I'm going to take about 10 minutes with each of these three topics and with a different speaker for each to run through some basic questions and provide some more details. And then again, we will circle back at the end to provide an open Q&A session. But I'm going to start off by bringing in Dr. John Ellis. And John, thank you again for being here. If we could just start off by telling us a little bit about your role and responsibilities at Nextgen as it relates to the Cures Act.
Sure thing. Thanks, Chris. Well, as Chris mentioned, I'm Dr. John Ellis, and I serve as the Vice President of the Regulatory and Clinical Affairs team here at Nextgen Healthcare. I am a board-certified family physician, and we've actually been using Nextgen's Enterprise EHR in my own clinical practice for nearly 20 years now. Moreover, I have the privilege of managing an amazing team of individuals here at Nextgen Healthcare who are directly responsible for ensuring the regulatory integrity of our portfolio of solutions. Among other things, this group is responsible for ensuring that our applicable products meet the ONC certification requirements. And as Chris mentioned earlier, I'm very, very proud to say that we were the first complete EHR solution to achieve the full 2015 edition Cures Update certification for our enterprise product.
Quite an accomplishment, certainly, and I can say I'll add for all of those of you listening, in the rule, there are hundreds of pages of what goes in the certification, and then ONC puts out, thousands of pages more of technical specifications of what you have to meet. So it's certainly a big accomplishment, and I'm curious if, you could add a little more color around what the process was like for Nextgen's Enterprise EHR to gain certification, from looking through those rules to testing and, ultimately what you had to change about the product that, folks might see as it comes out.
Well, to be sure, the certification process for EHR vendors is certainly rigorous and extensive. Ultimately, it involved over 2 years of work for our Enterprise EHR product. With that said, I suspect that what most of the audience would actually like to know is, why is certification important? And what does it actually mean for them as healthcare providers? To begin with, I think it's important to understand the context, as Chris has shared previously, in that ONC has established standards for structured data, security, and interoperability that health IT software must meet in order to become certified. With the Cures Act, the government mandated new and updated certification capabilities along with new business processes. Those were some of the things that you saw Chris mention earlier. And EHR vendors must comply with each of those requirements now. So again, it's very, very extensive. Some of these new certified functions are focused distinctly on enhancing interoperability and truly improving patient access to their health information. And I think, again, just to kind of reiterate what Chris has already touched on, this probably more so than any other element of certification is really the focus of the government right now. So some of these new capabilities that are now mandated as a matter of the Cures requirements include expanded EHI, electronic health information requirements, as well as support for the latest HL7 FHIR standards with respect to APIs. So for you all as users of certified health IT, you're going to want to make sure that you are using all of the capabilities that are kind of called for in terms of these new interoperability expectations. Now, ONC certification itself is a voluntary program for health IT vendors, but healthcare providers must use ONC certified software in order to be eligible to participate in and receive Medicare and Medicaid incentive payments and avoid reimbursement penalties. So again, Chris has kind of touched on some of this, but the end result, and in effect, the use of certified software is required not only for things like the promoting interoperability performance category under MIPS, but also for programs, that you might not immediately think of, things like Primary Care First, the Chronic Care Management Incentive Program, alternative payment models, certain ACOs, and really a variety of other federal, state, and private, even private payer programs in some cases. So all of those things are important considerations, without a doubt. But perhaps the most important and relevant is the fact that at the end of the day, achieving conformance to the most recent certification criteria, and in this case, we're talking about the Cures Update requirements, that really allows providers and patients both to feel a level of confidence and assurance in the way that their health information is stored, used, and shared.
Yeah, excellent points. And I think it's interesting to consider that the rules had, primary responsibilities for EHR companies to achieve this certification, but then there's a secondary responsibility on the healthcare providers as to when they need to be using it. On that point, if you could just drill down into exactly when, to clarify, which providers need to be using this new certified health IT and when do they need to be using it by?
Yeah, great questions. We've seen a lot of good questions on that topic coming in through the Q&A window. So as you alluded to earlier, Chris, health IT vendors are required to bring their certified products into conformance with the Cures Update certification requirements by December 31st of this year. So again, that's a time frame, a regulatory time frame that applies to us as a vendor, as a health IT vendor. For providers, on the other hand, the answer to this question actually depends entirely on the requirements of the individual programs that your organization actually participates in. So again, Chris kind of touched on this earlier, but important to reiterate it here. So for example, if your practice participates solely in the MIPS PI program, then you have a 90-day performance window to demonstrate all of your relevant quality performance metrics, and you will necessarily need to have a Cures Update certified version of your software in place by the beginning of that 90-day performance window, and obviously throughout that 90-day performance window. On the other hand, if you participate in a program that requires full year reporting, and those programs are out there, you'll need to make sure that you upgrade to the Cures Update certified version of your software prior to January 1st of 2023. It won't actually do you any good if you miss that deadline for taking the upgrade to the Cures Update certified version, because even if you were to get it implemented in your practice, say January 2nd, and you're in a full year reporting program, you will lose your eligibility to participate in that program.
Interesting. Thank you for clarifying that. And I know it has been confusing for many across these different programs when you think it's as simple as hearing, December 31st and you see a press release from the government, but then you have to crosswalk that rule with the other rules of participation in the federal program. So certainly a lot to keep our eye on there. I think one final question I would have, and I talked a little bit about that part 2 of the certification requirements, the required business practices and sort of ongoing maintenance and certification of maintenance requirements. What do providers need to know about this? I know there's a long list of things that you and your team have to do over the future now, build into the annual calendar and compliance requirements, but what should providers know? Are they going to have to do this this again in the future on an ongoing basis? And what does this mean for them?
Yeah, good question. So again, the most critical factor is to understand explicitly the requirements of the programs that your practice actually participates in. So, if your practice is only subject to a 90-day quality performance window, then you have a relative degree of flexibility in terms of when you can take an upgrade of your software, just so long as you have that Cures Update certified version in place in advance of that reporting window. I think it's also worth noting here that some practices may have a mix of reporting requirements based on the various programs that you participate in. So, even though you may participate in the MIPS PI program, for example, if you are additionally participating in a program that requires full year reporting, then that 90-day quality performance window flexibility is kind of out the window. You have to go with the least common denominator here, and that would mean making sure that you take that Cures Update certified version in advance of the January 1st, 2023 deadline. So the bottom line here is to ensure that you upgrade your production environment for your EHR to the Cures Update compliant version in advance of whatever your quality reporting window is. And again, if you're in a program that requires full year reporting, you necessarily need to have that in place before January 1st of this coming year. So one other thing, Chris, that tends to be a point of confusion, and again, you sort of referenced this earlier. There was a 36-month element that was referenced by the ONC in its rulemaking. This pertains very specifically to the electronic health information export criterion. So the EHI export functionality. As a matter of the Cures Act, ONC is requiring EHR vendors to make the EHI export capability available to its customers by December 31st of 2023. So they allowed an additional year for vendors to develop that capability and roll it out to its customer base.
A lot to dive into there, and it's certainly a lot for providers to keep track of those different deadlines and different deadlines into the future. And I also say it's, I understand December 31st is preceding January 1st, but it would oftentimes be easier if they just say it's January 1st or the new year to keep track of these deadlines. But thank you very much, Dr. Ellison. I hope you hang on for some questions at the end when we bring the whole team together. But to move along the discussion here, to information blocking, I'm going to bring in our information blocking expert, Andy Riedel. And Andy, to kind of kick things off, if you could do as Dr. Ellis did, just tell us a little bit about your role at Nextgen and your responsibilities as it's related to the Cures Act.
Sure. So, like Dr. Ellis, I work as part of the regulatory affairs team at Nextgen. In fact, he's my boss. What I do with that team is I provide education and support to clients as well as internally to different stakeholders, departments, as it pertains to various programs. So I have special expertise around the MIPS program, chronic care management program, patient-centered medical home, and also function as one of the subject matter experts, as you alluded to, when it comes to the information blocking rules. So I spend a lot of time on client education of our sales team, our support team, and other folks, because as I think everybody has kind of absorbed by now, this stuff is complicated and not really very intuitive.
So you're the guy in his free time who enjoys reading through the information blocking rules and FAQs to make sure you can answer everyone's questions, essentially.
When I was a child, I used to play info block in the backyard when other kids were playing, fireman or whatever. So,
As many of us were. So tell us, as I talked about the status of the information blocking rules, we have an effective rule, some questions around the enforcement, and some pending rules coming out. What's the bottom line? What's the status of those rules today?
So we are, since April of last year, we are really in a compliance status with the info blocking rule. So in other words, that was what they call the applicability date, and that meant that's the date that they sort of expect everybody to be compliant with the info blocking rule. We are still waiting for the Office of the Inspector General to do a final release of its rule for enforcement. The Office of the Inspector General will be the enforcement arm, it would appear, although they may share that duty with others. It's likely that they'll be the chief enforcement arm. So if there's a charge of information blocking against any actor, and as you said before, that could be a healthcare provider, it could be an EHR developer, it could be a health information exchange or network, that would go to OIG to follow up on. Until there is an enforcement rule, there's no schedule of appropriate disincentives, aka penalties for providers. And the government has said that they don't intend to retroactively investigate any of those, or at least charge anybody with info blocking retroactive to the passing of the rule. So but we're telling our clients, And certainly we're practicing as an actor ourselves under the principle that we're in a compliance period now and everybody should be compliant.
Right. I think that certainly makes sense and is certainly in the spirit of the law and the rules. So one of the probably the most controversial aspect of the rules, and I referenced this when I went over the overview of information blocking, is the requirement for the immediate release of lab results through a patient portal. Tell us what that issue is all about, what the rules say, and what providers have been asking about and doing in response to it.
Sure. So just a little level set, so the requirement under info blocking is to, upon request, respond to a request for health information, EHI, electronic health information as it's defined in the content and manner requested. So if a patient says to you, I would like to have any information, not just lab results, available in a timely manner as the law requires, and I'd like it through a patient portal. If you have a patient portal and the patient is registered on that portal, you could consider the fact that they're registered on that portal as a standing request. They expect to have the information available more or less contemporaneously with when the provider has it available to them. That doesn't mean you have to go out and buy a portal and provide information through a portal. In fact, I don't know if this is one of the questions that you had queued up for me, but one of the common areas of confusion is that the Cures Act doesn't actually require anybody to acquire any technology. You don't have to have a certified EHR at all, but the info blocking rule still applies to you. So if you have EHI, that paradigm is content and matter. If you have it, you share it. And if you can share it in the way that it's requested, that's what you do. If you can't, you discuss with the requester and make sure if they're, again, authorized to have it, like a patient or another provider, that you can do it in the way that they're asking or some other way. So lab results. Let's assume that a patient has a portal, or that you have a portal for your patients and that the patients are registered, and their expectation might be that anytime information becomes available, it should be available to them immediately, and that would include lab results or imaging results or pathology results. So any providers and clinicians and knowledgeable practice managers on the phone right now or on the call right now certainly know that this kind of rubs up against a long-standing practice, we might even say a best practice, where providers would hold certain types of results until they had all the information they needed in order to consult with the patient in a way that they determined would be in the patient's best interests. So maybe they needed some more data before they had a complete picture, or maybe there's some clinical context. There's other information that would be important for the patient to know that wouldn't be contained in a result. They might read the result and it might be potentially devastating news or bad news. And without any context clinically, it could cause major upset and problems with the patient. So this is, I'm sure pretty much everyone on this call understands this practice. They know about it. The controversy is, as far as the ONC is concerned, up until now, they don't really seem to care. So they say that you can use the harm exception or any other of the 8 exceptions under the rule on a case-by-case basis. You can't have a blanket policy that says, I'm going to...
Blanket policy.
Right. I can't hold all my lab results until I talk to the patient or sign off on them. Or you can't hold even just your positive results. However, if you have a specific patient that you feel could be harmed by having that information, it could be, or let's just say it's a pediatric situation where you wouldn't want a parent to see the result of a certain kind of test that they're not supposed to see, if you believe, or especially if you believe that there's abuse in the home. I mean, we could sit here all day and come up with examples that might be harm. That's fine. On a case-by-case basis, you can apply the harm exception. One interesting thing, and I find, I'm not a clinician, but I've been around clinicians enough to know that many of them would probably take exception with the kind of differentiation between mental or emotional harm and physical harm that ONC has laid out in the FAQ. So emotional harm, it wouldn't be enough if the patient was upset or emotionally harmed. It would have to present a significant risk of physical harm to the patient. And, as I understand it, mental health is part of the patient's overall physical well-being. So I would imagine many providers have a problem with that, but I don't know. I think we can expect some more clarification on this, and I would expect that would happen in the form of updates to the FAQ that ONC puts out.
Right. Yeah, and certainly, as you described, it sounds like the complexity of clinical practice is meeting the complexity of the rules in some way, and there's still some issues that are being sorted out there, and certainly highlighted in this issue of the release of patient results, which can be such a important moment for many patients and in the daily practice for many providers.
Yeah, and ONC has heard from the provider community on this, so.
Yeah, and I know there's, as I mentioned, some advocacy efforts, so we'll have to continue to monitor that and see what happens. As we kind of wrap things up with just one last question here, we're now, again, 5+ years in, we have the rules, we're waiting on the enforcement piece of this. When do you expect this to be fully implemented and enforced with provider penalties? And if we, as a useful comparison, maybe think of HIPAA, it came out and it started slow, and it too at one point was a young regulation that was not being enforced. When this is fully enforced, it'll be something that'll be built into practice training and something everyone has to be aware of because there's some penalties attached to it potentially. When will that point be in your estimation?
Well, I mean, to me, the point right now is everybody should have updated policies and procedures already as it relates to this. So the AMA, for example, suggests that updating your policies and procedures means having a policy for each of the exceptions under the info blocking rule, so that if you're going to apply that exception, you've got it written out in advance when you will, when you won't, how you document it, and so on. I mean, my suspicion is once they go live with enforcement, we can potentially start to see adjudication of info blocking accusations and charges immediately. So based on whatever the actual penalties are in the enforcement process, I think practices may need to go back to the drawing board. So, make some updates to the policies and tweaks, but until we see what enforcement looks like, we can't even begin to guess what that would look like. And as far as when the rule is expected, I mean, it hasn't even hit the Office of Budget Management yet, correct?
Right. So yeah, it could be a while. Well, to your point though, the rules are out, they're effective. We know what we have to do. It's just a matter of time. So I think, starting to put together a plan and stay ahead of these rules certainly makes sense at this point.
Yeah,
well,
I mean,
thank you, Andy.
I wouldn't be panicking if you haven't done anything, but I would also say you're behind the 8 ball, and you want to meet with your advisors and your medical legal team and start to make sure you have a compliance program in place.
Right, absolutely. Well, thanks again, Andy, and please do stick around for some questions at the end. To move things along to our third and final segment here around TEFCA, I'd like to introduce Mo Shabli. And Mo, if you could start out with just a brief description of your role at Nextgen and what you've been involved with as it relates to the CARES Act, please.
Sure thing, Chris, and thanks for having me. So I've been at Nextgen almost 10 years now, working in interoperability and data exchange. I started in my role as a product manager for our HIE connections, so getting Nextgen EMR customers connected to local and regional and state HIEs. And over time, my responsibilities have grown to include Nextgen Share, our interoperability hub in the cloud. And today, my team and I are responsible for many aspects of our interop and data exchange business, including our open source integration engine, Mirth Connect, obviously Nextgen Share, our integrations with care quality and direct messaging, and also our HIE facing solutions, our data aggregator facing solutions with a product that we call Health Data Hub. And in that sense, TEFCA really directly impacts our group and our HIE and data exchange customers of all types, including ambulatory EMR customers. So yeah, thanks, Chris, for giving me a chance to just give a little bit of that background.
Yeah, and as I understand, as I spend my days mostly trying to make sense of complex laws and regulations, much of what you do is the same around interoperability policy. And as I look at this chart here, how will data exchange work? This is pretty confusing to someone like me and to many providers, I'm sure. Just in your own words, explain what TEFCA is and what providers need to know about it.
Yeah, absolutely. So I think it's like everything else and all projects that we start, it's always important to start with why, right? Like, what are the goals? What's the mission? What are we trying to accomplish? And for TEFCA, there were three main goals that were established as kind of part of the drafting of TEFCA. Number one was this idea of establishing a universal policy and technical floor for nationwide interoperability. So what are the rules of the road? What are the policies that we all should implement that make interoperability basics the same everywhere, right? That's kind of one of the stated goals. The second stated goal was to simplify connectivity for organizations to actually exchange information, right? And this is kind of maybe summarized in this idea of a national on-ramp, right? An easy way for everyone to turn on connectivity that gives them access to everyone else that's in network or part of the exchange continuum. And then the third stated goal of TEFCA was to enable individuals to gather their healthcare information, right? So there's like this common cliche in healthcare, and I'm sure we've all said it, that like we are all patients, and that's absolutely true. But once you have interactions in the healthcare system, you learn that like there's vast differences between the technical data exchange and data access capabilities of one organization versus those of another organization, right? And anybody who's seen more than one doctor knows that like one clinic, you can easily get access to your data on your phone, mobile app, easy API, great portal or great tools. And another provider, you may not have any access at all and no ability to see what those records look like or interact with the clinic digitally. So the idea is that providers and healthcare organizations who have an easy on-ramp, right, a national on-ramp, would, by virtue of that on-ramp, be connected to everybody, but then the patients, most importantly, as individuals, should be able to gather their healthcare information. And I think looking at this diagram, Chris and Andy and Dr. Ellis, we've all been around for a while, right? We've heard tell of national networks and interop and care quality and direct messaging. A lot of those goals that I just described, they sound a lot like the goals of some of those previous efforts that are national, but also local, right? State and regional HIEs try to provide a lot of that same TEFCA-like functionality that you've heard us talk about. But the difference between the things that have come in the past and what TEFCA is trying to do today, I think, is the scope of the overall effort. The level of interconnectedness that this future state diagram is trying, to set a stake in the ground and say, here's where we need to go. It's much more ambitious, I think, than some of the earlier efforts. And so that's, to its credit, a very exciting and, I think, forward-looking opportunity. The challenges, I think, are like, how do we explain all of this to people in a way that's understandable? As you said, Chris, like,
exactly,
this is all today optional, right? A provider could look at this and say, oh, there's no penalty for not participating. I'll see you later, right? Call me when it's required. And I can definitely understand that drive. But on the flip side of that coin is a scenario that, like, once these QHINs, these qualified health information networks, are in fact stood up, and once they can exchange data with a local HIE as easily as with a national network, and once there's providers and health systems on board and apps, that within a QHIN network, there'll be robust exchange. And QHINs will be expected to enable QHIN to QHIN exchange at no additional cost, right? So organizations would be required to share data with one another. And because of like that first goal that I described of that common rules of the road, every participant in this diagram, whether you are a participant or a sub-participant, will have agreed to the same flow down provisions, the technical privacy, security, and cooperation clauses of TEFCA that will mean that, we're not going to treat organizations differently because they're a competitor, right? So there's clear messaging around something that's called non-discrimination. There's clear messaging around confidentiality and permissions. And these are all very significantly different than previous interop efforts because the goal is more broad reaching. And that's kind of like the story. And so like the one piece I want to touch on in this diagram is the umbrella, right? So here the umbrella, this RCE, the recognized coordinating entity that has been designated by ONC and HHS to describe the policy and governance and technical requirements. As Chris said, that is the Sequoia project. So Sequoia is not new to any of us, right? They've stood up the eHealth Exchange. They run Care Quality. It's a known, very well respected organization that has a substantial track record of data exchange and is going to bring that same, policy and process and like technical diligence to running TEFCA at a national level. So organizations like Nextgen, have a choice to make, right? Where do we see ourselves fitting into this picture? And some EHR companies are going to decide to stand up their own QHIN. Other EHR companies are already participating with some of the national network players like eHealth Exchange or Commonwealth, and they're likely just going to stick with the QHIN that brought them, right? Stick with the network that they're already on and already participating in. And so there are choices here that organizations will have to make at some point in the future. I'll wrap on this slide by just saying, like, we've already seen this pattern play out in other programs around interop or payment arrangements where things can start off completely optional and you don't have to participate and you can sit back and watch how things develop. But we've seen this play out in the past where things that start off optional quickly become part of, other payment arrangements or programs in the future. We don't have any indication right now that that's immediately happening with TEFCA, but you can expect that the effort that's gone into, since, the entire history that Chris laid out for us on the drafting of 21st Century Cures, you can expect that this is something that will continue forward and be expected to deliver on that national interop, those three goals that I mentioned earlier. So right now, I think I would encourage people to be on the lookout for messaging from your vendor of choice, the interop, org that you're partnered with. Maybe that's your EHR, maybe that's us, Nextgen. But be on the lookout for messaging about what that organization's plans are for TEFCA. And certainly consider whether you want to participate with that or not.
Yeah, and thanks for clarifying all of that. Extremely helpful. And as I look at that diagram, I certainly have a better understanding of it now. But to your point on voluntary, as I often say, the government doesn't necessarily do voluntary well. They're not in the business of voluntary. So we'll have to continue to monitor to see what happens there. As the draft one was finalized in January, and you talked about QHINs coming on board at some point, when do you see that happening? When do you think this will hit the market in terms of provider impact from a timeline perspective?
Yeah, great question. So we've already seen some public announcements from some organizations announcing their QHIN interest or their goal to become and stand up a QHIN. We also have heard from some of the national networks like eHealth Exchange is likely to become a QHIN. Commonwealth is making all the right rumblings that they will stand up a QHIN, and others as well. So I don't want to single or call anyone out individually. But there's going to be more messaging around this, and I think at the end of this year, third and fourth quarter, we'll see I think the bulk of the announcements, even potentially the first organized and confirmed and tested and validated QHIN should happen before the end of this year, if I'm not mistaken.
Interesting. So it's a evolving discussion, and as with all these other rules, you see the final press release, TEFCA finalized, but the story continues. So like we saw with certification and with info blocking, December 2016 then becomes late 2022 when we start to see some of the implications here. So I think across all of these different provisions of the Cures Act, we're seeing that we're at an interesting time now where they've taken a few years to develop a consensus, go through some draft policies, draft rules, and they're actually starting to hit the market. So I think it's certainly a to be continued discussion around whether or not this has been successful. We'll have to see once these provisions have really gone into effect and hit the market and hit the provider community and the vendor community to see what the impact has been. But I think it's an exciting time in that we've finally gotten to that point where that's going to happen. So with that, I think we've gone just a tad long, which is not surprising given the breadth of the content here, but we do have some time and did want to address, we have quite a few questions coming in. And I think I'll just kick it back to our panelists here if you've had a chance to monitor questions coming in. Anything you wanted to address? I know we've addressed a few here in written form, but anything, Dr. Ellis or Andy or Mo, that you wanted to address verbally that would benefit the crowd here?
Yeah, sure. I actually made a couple of assignments too here. Mo, I sent a couple over to you, but I think you actually talked about it towards the end there where QN is concerned. Here's one from somebody that wants to know about MIPS quality. What about the CQMs and the quality reporting? It only seems to be required, it being the Cures edition or Cures update, for PI reporting for 90 days. Actually, the rule for quality is that you need cert by the final day of the reporting year. So if you're only reporting quality, then, and you're not reporting PI, I should say, then, and that could happen through reweighting or any number of things, then you could potentially hold off till the end of the year. But you'll want to talk to your EHR developer because these measures get updated from time to time, and you want to make sure that you're using the latest version of the measures.
Andy, let me chime in and answer one of the questions that
Sure.
did come in about our awareness of entities, and then the question about HIEs who may be interested in QHINs. So I did mention that Commonwealth and the eHealth Exchange are likely to become QHINs. And you might be asking, like, what's up with care quality? Why isn't care quality mentioned? Well, today, care quality is part of Sequoia. And just the way that eHealth Exchange and Commonwealth are set up, they have record locators, especially on the Commonwealth side, there's a record locator. That's kind of one of the core aspects of what QHINs are expected to deliver, and care quality doesn't quite have that. So there's some technical challenges there. But the bigger issue on the care quality side is a policy question that because they're part of Sequoia, they're playing kind of this dual role where they're the administrator of all of TEFCA. Can they run a QHIN on TEFCA? And it's not likely that care quality will announce that they're going to become a QHIN. Rather, the participants in care quality will likely want to or have to move to a different QHIN. And so there are options. And I think when we have not made any announcements ourselves about our QHIN plans, but you can imagine that, like with Nextgen Share, our interoperability hub in the cloud, we have a lot of the technical components. That is part of our current evaluation. So I don't have anything to announce right now, but later this year, we're going to see a lot more news about which vendors are interested in standing up a QHIN and which ones will just participate with one of the established larger national networks. So definitely.
And there was also a question about QHINs, like, and if I'm interpreting it right, so the info blocking rule doesn't require the use of QHIN infrastructure for collaborative care across platforms. And I guess if we're talking about healthcare providers as actors under the info blocking rule, there's no requirement to join any kind of network, right? Mo, you're on the same page with me about that, I assume.
Yes, absolutely right, Andy. There's no technical requirement to join any network.
So let's see, what else do we have on Q&A? I had a couple more. We have a couple more minutes. So
I'll address one real quick. It's an easy one.
Sure, go ahead.
Is it true that 2022 is the last performance year for the paid 5% bonus in 2024 through MACRA? That is correct. For both the $500 million in incentives in MIPS, as well as the 5% bonus for advanced APMs, 2022 performance is the last year. There are advocacy efforts to extend that, but as of yet, they've been unsuccessful. Go ahead, Dr. Ellis.
Yeah, I was just going to comment on a similar question here. Somebody had asked, will providers that do not participate in other CMS programs be required to utilize Cure certified EHRs? The answer to that question is maybe. And the reason that it's a little equivocal is because it's entirely dependent on the requirement of the program that your organization participates with. And to more directly answer the question, there are non-CMS programs out there that do in fact require the use of certified technology. So it's something to really, really take a close look at. not only, just at a global perspective in terms of the programs that you participate with, but actually with your payer contracts as well. We've run into some rare instances where payer contracts have some very obtuse language in it referring to the required use of certified EHRs, but they do not, at least in the examples we've seen, they do not actually specify the addition of the certification. So just take a very, very close look at the programs that you're participating in.
I'm just trying to look in the last minute we have here if there's anything else sitting here that we haven't answered. I don't think so. Just for those of you who are Nextgen clients and who had specific questions about versions and things like that, I tried to answer you privately, but feel free to reach out to us either directly or through your account rep. Also go to the Success community and look at the FAQ and the different information we have there. But just keep in mind that Cure's update does apply to a specific version of our EHR.
Yeah, and
got it covered. I think
yeah, I think we see a few product-specific questions, as Andy mentioned. We'll feel free to reach out and we'll get you on that. But thank you everyone for attending. I think it was certainly an interesting discussion. Interesting to reflect as we're 5 years plus from the law being passed as to the status of these various different provisions, and certainly for the four of us who have spent a lot of time over the last 5+ years working through these rules, just from the law came out to when the rules were in draft form to final form to actually now seeing your questions as they hit the market. It's a more interesting part of the discussion than Andy sitting at home in his backyard reading through the info blocking rules without anyone to talk to about it.
Right.
And with that, I think we'll say thank you and depart for the day.
Thank you, everybody. Great session.